National Perspectives Plenary Session, a Fireside Chat. This is a session that really is developed in order for some of the heads of our national agencies to have a chance to tell us a little bit about what their agency is doing and then respond to some questions and have a dialogue, have a chat about some of the issues that are important to us as ACM members. So we are going to go through and have each of our three esteemed panelists talk a little bit about for 5 minutes, for some slides, about what their agency is doing. And then we're going to go into some questions and answers. If you would like to submit a question, then you would need to go to the app. So if you were to look at the conference app, and first you need to go up to this session, which is not this one, go to the correct session on top, and you'll see at the bottom there's a little button for polling, and push polling. You'll put your question in the Ask Question area, and then of course you would submit it. And that will go to our staff who will be culling through the different questions that have been asked. Could we go to the next slide, please? And the next slide, please. And be able to give me those questions to ask. So our three panelists will be hearing from Dr. George Koob, who is the director of NIAAA. We will be, next slide, please. And the next. Technical difficulties.
I think you can.
I'll do it. Yes, good. Dr. Wilson Compton, who is the deputy director of NIDA, National Institute on Drug Abuse, and Dr. Debbie Dowell, the senior medical officer, chief medical officer for the CDC, or Center of Disease Control. So 5 minutes for slides for each of our presenters. I think we start with Dr. Koob. Go.
Okay. Well, thank you, Arlene. Oh, no, it's not Arlene. Anyway.
Looking at Arlene.
I'm looking at Arlene.
Do you have a mic?
I think so. Is the mic working?
No, it's fallen onto your lap.
Oh, I'm just creating chaos.
No, it's the technical difficulties. That would be me.
Okay, so this first slide I could take the whole time on, but I just want to make a couple of major points. First of all, alcohol use disorder continues to be a major problem in the United States. We lose about 90,000 people a year due to alcohol use disorders. I think one of the more salient points is half of liver disease in this country is caused by alcohol now. And I think the most important one for this group is that less than 10% of people with an alcohol use disorder get any treatment whatsoever, and fewer than 5% or 4% receive pharmacotherapy. So our strategic plan and our focus is to identify mechanisms of alcohol action, pathology, and recovery, improve diagnosis and tracking, develop and improve prevention strategies, develop and improve treatments, and enhance the public health impact of NIAAA research. I've made it a major goal since I've become director to get our evidence-based information out to the public for use. And in that regard, we have some new and exciting research on fetal alcohol spectrum disorder. We have new diagnostic tools for fetal alcohol spectrum disorder. A recent paper just came out showing that the prevalence of fetal alcohol spectrum disorder in this country is as high as 1 to 5%. That's up there in the range of autism spectrum disorders. We're very proud of our treatment navigator. I think many of you have checked it out. I urge you all to try it and see what you think of it. We welcome any feedback, but the purpose of this is to outline features of evidence-based alcohol use disorder treatment, describe the various routes to recovery, and provide a strategy for locating qualified treatment specialists. There are 2 locators associated with this. One is SAMHSA's locator, the other is Psychology Today. We're beginning to work with the American Psychiatric Association and the Liver Society in possibly developing a more streamlined physician, clinical psychologist version of the treatment navigator for treatment providers. I think it's really important that you understand that while we have a threefold decrease in adolescent drinking in this country in the last 10 years. That's a very good news, a threefold decrease in adolescent drinking. What we do see is a pretty dramatic increase in binge drinking and extreme binge drinking in the population. And this slide illustrates this, and you will note that it parallels the same increases to some extent that you see with opioid use disorder problems. In the extreme binge drinking, we know that these individuals have a much higher risk of emergency room department visits, particularly when the extreme binge drinking moves into the range of 3 times a normal binge drink. We also know that there's very little information about women and alcohol from the biological perspective, but we also know that women are more vulnerable to some of the pathophysiology associated with alcohol, and we know that women are drinking more and catching up with men in alcohol use in the United States. And then for us, in my age group, there's also been a steady increase in drinking and even in binge drinking over the last 10 years. We're well aware of the issues associated with co-occurring morbidity and alcohol use disorder. It ranges from PTSD to opioid use disorder. This is an area we're working hand in hand with the National Institute on Drug Abuse and the National Institute on Mental Health. And I applaud what ASAM and ABAM has been able to do on the development of addiction medicine specialists and also addiction medicine fellowship. We would like to continue this work, and we are continuing this work with you all, but with every group from medical schools to nursing schools to pharmacy schools. And I thank you very much. I did that in 5 minutes. I hope you.
Well done.
Well, thank you. It's a pleasure to be here, and I'm certainly so pleased to be speaking with my colleagues, Dr. Koob and Dr. Dowell, because it's wonderful to remind us that while I'm going to talk to you about opioids, that's not the only substance that we care about in the addiction field. It is certainly the primary issue that we're reading about in the news of late. And I hope that we can use this crisis both to come up with active and useful solutions for this scourge that's devastating so many communities. But I also hope we can use it to change the way addiction is treated across the board, so that we can be better integrated into general medicine, that we can see the welcome wagon and the welcome mat that we receive now across all of healthcare as a way of changing the entire field of addiction medicine. It's really a remarkable time right now. Now, I'm going to zip through a number of areas that just focus on opioids, but of course, if you have questions about cocaine, development, prevention, tobacco, I'm welcome to address any of those because our portfolio at NIDA covers a very broad range of substances. We certainly have focused on saving lives acutely through working in public-private partnerships to develop novel ways to administer naloxone, the nasal spray, and we also saw the auto-injector developed recently. I was so excited to see the Surgeon General issue guidance just a couple of weeks ago, or 1 week ago, encouraging the public to have naloxone readily at hand to save lives acutely. So that it's not just the librarians in Philadelphia who are saving lives, but it may be many, many members of the public that when they see somebody who may have overdosed, they can use this life-saving medication. Now, this isn't the only way that we can do the research. The question is, are there novel approaches that may be longer-acting agents that address fentanyl risks? Might there be sort of general respiratory stimulants that could cut across the board and not be only for opioid overdoses, but other overdoses as well? A second key issue that's more in the service delivery area has to do with where the opioid crisis takes place. It's in rural and suburban areas disproportionately. And so how do we get services into rural areas? Scott County, Indiana was a prime example of the HIV-HCV outbreak, and yet there was almost no public health or medical infrastructure in that county. So we've launched a series of studies in collaboration with SAMHSA, CDC, and the Appalachian Regional Commission to come up with models of care for rural areas. In addition to overdose, in addition to the medical and infectious disease comorbidity, neonatal absence syndrome is another major theme. We've been supporting work that suggests the increasing rates of neonatal abstinence syndrome, the increasing cost for Medicaid. We've also been working on novel treatments, whether that's buprenorphine instead of the standard morphine that's often used for these newborns. These are some of the ways that we're supporting work. When we focus on addiction treatment, which of course is going to be of most interest here, we have a number of studies, and I highlight for you the wonderful work coming out of Yale with administering buprenorphine in emergency departments. I'm really pleased that we've been working on educational materials for emergency physicians in collaboration with the American College of Emergency Physicians that should be released quite soon, building on some of this work. We've seen Josh Lee and colleagues' work reminding us that even people on supervision, on probation and parole, can benefit from medications, and it can markedly improve their outcomes. Most recently, we had the clinical study that showed the generally equally safe and effective outcomes for extended-release naltrexone and buprenorphine naloxone combination after induction. So you still have the difficulty of getting people onto the extended-release naltrexone, but once they're on it, they seem to do about equally as well, and that was a very important project. Just a couple of weeks ago, we saw a new medication receive recommendation from the FDA Advisory Committee. This doesn't mean this medication is available yet, but a new medication for withdrawal, we hope, will be available shortly. Now, I'm just going to end by reminding us that it's not just NIDA, but it's all of the NIH that's focusing on the opioid crisis. We're very pleased that Congress has allocated a significant new appropriation to expand research addressing the pain crisis and trying to develop novel approaches to pain that don't rely so much and so unnecessarily on opioids, as well as significant funding for improving opioid addiction treatment and opioid reversal. And you may be able to read about the HEAL initiative, H-E-A-L initiative, that's just been launched and announced by NIH in the last few days. Thanks very much.
Good afternoon, everyone. It's so great to be with you here at ASAM. Like Wilson, I'm going to focus my remarks on opioids. As you all know far too well, far too many people in the United States are struggling with, sorry, I'm going too many slides. Okay, far too many people in the United States are struggling with opioid use disorder, at least 2 million according to data from the National Survey on Drug Use and Health. And from a population perspective, we have two really big, challenging, but important tasks. One is to prevent more people from becoming addicted in the first place. The other is to help the millions of people already struggling with opioid use disorder. And a few people now have proposed a model for how we can approach the opioid use disorder epidemic in the United States, like using the HIV cascade of care model. Starting with, I think, Socius, Volkow, and Wood in 2016. This is a graph from Arthur Robin Williams and colleagues kind of plotting out some of what we know, showing that if we were able to get people with opioid use disorder, 90% of them diagnosed, 90% of those engaged in care, 90% of those on MAT, 90% of those retained at least 6 months, and 90% of those in long-term recovery, we would have the blue bars would fill up all the pink bars on this graph. But as you can see, we're kind of far from that. The blue bars show an estimate of where we are. And coming from CDC as a public health agency, most of our efforts on opioids have been focused on the far left bar, preventing people from becoming addicted in the first place. And we think this is critical, and it will reduce the numbers of people struggling at each step along the way, as well as the resources required to get them there. And there are other agencies, notably HRSA and SAMHSA, focused at other steps on this cascade. But CDC also is doing work all throughout the cascade, and I'm happy to talk about the left bar. That's what I talk about all the time, but I think people are more familiar with that, and since I only have a couple minutes, I'm going to talk about some examples of what CDC is doing throughout this continuum. Linkage to care. CDC is seeking innovative ways to link people to and retain them in treatment. For example, we're supporting 13 community-level projects to respond to spikes in opioid overdose. And 6 of these projects include linkage to MAT, 2 facilitate buprenorphine induction, 3 are aiming to increase use of MAT among populations who are incarcerated. In addition, for the researchers out there, CDC intends to commit up to $15,750,000 over the next 3 years to support up to 7 applications to develop and pilot or rigorously evaluate novel prevention interventions. And responsive applications may include testing interventions that enhance linkage to and retention in MAT. Many other examples of responsive projects are described in the Notice of Funding Opportunity on grants.gov, and the application is due next month. I wanted to talk about, this is one of the most inspiring studies I've seen recently. It's already been mentioned at this conference. Tracy Green and colleagues published this online in JAMA in February, JAMA Psychiatry. And I'm proud that CDC helped support the study along with NIH. They found, as you may have heard, that the implementation of a comprehensive MAT program at the Rhode Island Department of Corrections, along with community centers of excellence to facilitate continuity of treatment upon release, was associated with a 60.5 reduction in overdose mortality among recently incarcerated individuals in Rhode Island. How often do we find an intervention anywhere in medicine with a 60% reduction in mortality? So I think this was a really important study. CDC promotes use of opioid use disorder. The 2016 CDC guideline for prescribing opioid for chronic pain recommended that clinicians use usually buprenorphine and methadone, opioid agonist, partial agonist, for the treatment of opioid use disorder. And our implementation efforts include a focus on increasing use of MAT, for example, through academic detailing efforts, our online web training, and whenever we speak to insurers about the guideline, we have 5 asks for them, and one of them is asking them to eliminate barriers to MAT, such as prior authorization and lifetime limits. And finally, to fill in gaps about what we don't know about MAT, including factors associated with retention, long-term, and treatment, CDC is planning to follow 3,500 patients over 2 years, regardless of whether or not they're in treatment that whole time. And the main outcomes are listed on the slide, and we anticipate finishing enrollment in January 2019. Thanks, I'm looking forward to our discussion.
Thank you. Thank you. Well, we have an opportunity here to ask some questions about some potential research opportunities for our members. So I'll start there. So I'd like to start with questions. Let's start with the youth. So Drs. Koob, Compton, in February, NIH released data from the ABCD study. So could you share a little bit about what information that we hope to get from that, and what kinds of studies those data will be funded maybe for use by your agency to do some research around those data?
Well, I'll start, and we'll let Dr. Koob clean up. The ABCD study is the Adolescent Brain Cognitive Development Study, and it has several innovations. One, it's a planned study of about 10,000 youth to look at what happens as they develop through adolescence, and some of them will pick up tobacco, some of them will start drinking, some of them will use marijuana and other substances. In addition, they'll be exposed to a whole host of environmental factors, whether that's head injury in sports, whether that's peer interactions, whether that's family interactions, whether that's prior history of problems. So the key innovation here is that we're examining them and starting with the MRI scans prior to any of this happening at around 9 and 10 years old. The other key innovation is that this study has a rapid release of data, so that the first 4,500 subject, the MRI scans and the neuropsychiatric evaluation of those individuals has already been released at baseline. Now, certainly we're not going to be able to tell you anything about their substance use from these first 4,500 of the 9 and 10-year-olds, but you'll know a lot about normal brain development and normal brain function, setting the stage for understanding how much of the trajectories that we've observed in adults are due to issues that happen prior to exposure to substances or influenced by alcohol, tobacco, and other drugs later in their adolescence.
Well, I think Wilson really adequately and exhaustively described the study. I think the advantages from my perspective is that we are going to be imaging these individuals every 2 years, and we will be able to look at the interaction between the environment and the brain, and that's something that we really never been able to do before. So it's a new frontier from my perspective. You always wondered, was it the brain, or was it the environment, or was it the interaction between the two? And hopefully we'll be getting saliva, we'll be getting bloods from many of the samples. We may even be able to, dare I say it, get some information about epigenetic interactions.
We can hope.
We can
I
hope.
would also point out that this builds on a prior study that NIAAA has been conducting over the last number of years. And so that really is we learned so much from that project on how to launch this.
Yeah, the NCANDA, we call it, the National Consortium on Adolescent Neural Development with Alcohol. And we actually have data with NCANDA because there's a group, there were 900 subjects in this study, and a group of them actually exceeded drinking norms when they entered the study. And we already have data showing that they have compromised culling of neurons in the frontal cortex and compromised development of tracts moving back to the brainstem. So there's a lot of exciting data going to come out of the ABCD study.
That is exciting and distressing, both.
Correct. Correct.
Well, let's stay on the issue of youth then and talk about e-cigarettes, because to me, e-cigarettes are really about youth. NIDA recently released the standard research e-cigarettes, and maybe you could talk a little bit about how you expect this product to be used and helpful in doing research, and the kinds of research questions you think are still out there that are major questions for us to get more data on. And then I'd certainly like to hear a bit about some of the latest data out of the CDC about e-cigarette use, particularly among youth, that perhaps our members should most need to hear about.
In the current issue of the Journal of Addiction Medicine, there's an article about how e-cigarette products say on the packaging that they have what, 16 milligrams of nicotine, or 12, or none. Guess what? That's not how much they have. They have quite a variety of nicotine in those products. Those that say they have none often have more than none. Well, if I wanted to create a product that looks on the packaging like it's not habit forming, it's just flavoring, it doesn't have anything that's reinforcing, but I put just a little bit of something reinforcing in it, that really could be a way of shaping behavior. So I think that's very concerning. Because the packaging and because what we get in the commercial sector isn't reliable or consistent, we really need research tools so that we can consistently administer e-cigarettes to adults, to those who are already using them, and determine what happens to them and use them in a systematic way. That's why we developed the research e-cigarette, and we're just seeing it begin to be launched. I certainly have a hope that it can be used to be tested for those that are confirmed tobacco smokers and have tried other means of quitting smoking and want to try this as a mechanism. We really have so little data on whether e-cigarettes are useful to help people quit. I have that as a long-term goal, but it should be a very useful research tool. I will also just take a moment to point out that there is a new product on the market called Juuls that has taken the country by storm. It occupies a remarkable percentage of the marketplace for e-cigarettes right now, just in the last few months or year. CDC just released a series of documents reminding the public about the potential concerns of this because so many teens are using it. And all of the Juul products contain significant amounts of nicotine, so they would not be recommended for 16-year-olds.
Yes, that's a great point. And Juul is also marketed, it looks like a USB flash drive. So parents and teachers may not be aware that kids are using this. And to your question about the data, if you look overall at the National Health Interviews Survey data on e-cigarette use, if you look at current use among adults, it's been relatively flat the last few years, between 3% and 4%. But as you were noting, I think the concern is who's using them. And we see actually the most use and the biggest increase in use in exactly the populations where we expect the most harm and the least benefit. So For example, in middle school students from 2011 to 2016, the percentage using has gone from less than 1% to over 4%. And among high school students from about 1.5% to 11.3% in that amount of time. Also, even among adults, ideally, if people are going to use it, you would want it to be people who are trying to stop combustible tobacco and have stopped. But that's only 30% of the adult users. There's 11% who are using them before they've used any other tobacco products, and the overwhelming majority are using them along with other tobacco products, which we know from a secondary analysis that just came out may actually be detrimental to people's attempts to quit other tobacco products.
Thank you for even more distressing data. Okay. I actually have a bunch of distressing questions. This is, okay, so from youth, let's move to some older folks. Another emerging issue is the increase in the number of people over 65 who seem to be drinking excessively or in a risky manner. So Dr. Koob, maybe you could talk to us a little bit about how we might talk with patients and advise them about any particular health risks for the over 65 population with alcohol use.
You know, this population, of which I'm a member, proudly, I've lived this long, is particularly vulnerable to alcohol interactions in a number of ways. So first of all, if you excessively drink and you fall, you can break something, and it takes a lot longer to heal when you're my age than when you're younger. Secondly, individuals in this age group are usually taking medications, sometimes lots of medications. And most of you have heard me say this before, but when it involves alcohol and other sedative hypnotics, including opioids, 2 + 2 = 5. And so alcohol potentiates the lethal effects of all sedative hypnotics. And even benzodiazepines can be lethal if combined with alcohol. So I think those are two of the most major issues associated with the elderly or the aged population engaging in excessive alcohol use.
Thank you. Thank you. So I'd like to go back to the prevention issue again and pivot a little bit to the opioid crisis that we've spoken about earlier. The CDC has been doing a terrific job of educating the public, including prescribers, on the risks of the use of opioids to treat pain. But as we see finally the prescribing of opioids take a decrease, we don't see a corresponding decrease in a death rate, which I attribute to what I learned in economics class, which is if you've got supply reduction without demand reduction, you're going to get an increase in price and the development of substitutes, in this case heroin and fentanyl. One of the things that we know in terms of prevention is that while about 50% of the risk for developing addictive disease is genetic, which we cannot change yet, about 50% are environmental issues. And some of the risk factors that can be changed are chaos in the home, absent parents, dead parents, abuse and neglect, and etc. So that the effective treatment of an adult with opioid use disorders can be primary prevention for their children. During the time of the AIDS crisis, the CDC sent a mailer to every home, residential address in the US talking about HIV disease. And I'm just wondering if you could share any plans that the government has about educating people about what effective treatment for opioid addiction looks like, rather than just what they may think of in their head as generic treatment.
I think that's such an important point, Kelly. And there was a thought piece that came out in the New England Journal a couple of months ago looking at polls on opioids among the American public and pointing out that very few Americans know that there is effective treatment for opioid use disorder and that it's MAT. I think that's a critical gap, and I think it's tragic that so many resources and lives are are squandered when we even when we get people into treatment, which is not nearly enough of the time. It's so far too often not effective treatment. I think that's a critical piece. And as you know, CDC has launched an RX awareness campaign about the risks of prescription opioids, and we are looking into expanding that campaign to deal with some of the other issues you brought up, including risks of illicit opioids and other messages. So.
I would suggest that the barriers, not just with the public, but also with our clinical colleagues, that educating general physicians and others about the availability and effectiveness of medications for opioid use disorder is not a waste of time. There's still many people who don't understand, many of our colleagues who don't understand the potential benefits and the value of having collaborations with all the people in this room so that they have appropriate colleagues to refer patients to or to provide the guidance when something's more complicated than they can handle.
Mm-hmm. Well, we certainly have an underutilization of the FDA-approved medications for the 3 disorders that exist now. But we really only have medication treatment for alcohol, opioid, and nicotine addiction. We have an emerging, increasing problem with stimulants again. I'm wondering if you see any developments here on the horizon on treatments specifically targeting stimulants.
Well, when we think about stimulants, I'd include in that broad category both amphetamine, methamphetamine, as well as cocaine. And of course, the National Institute on Drug Abuse has made this a major priority. I can't say that we've had success in developing medications that I'm able to launch and have you all take advantage of. We continue to work on this topic. I'd say it's not just medications. We're looking at the possibility of magnetic stimulation being a novel approach to potentially strengthen the frontal striatal pathways as a way of addressing the decision-making that's such a key part of drug addiction. And that looks like it may be particularly useful for stimulants. There's some preclinical work, and now there's a number of clinical trials, small, but that's how we start to develop new treatments.
Well, I'd like to thank you for giving me a piece of data that's not distressing today. It's, thank you. Thank you. I'm feeling better now. Back to some distress. Dr. Koop, would you think that there's any value in perhaps a public service campaign around the dangers of mixing opioids with alcohol? We see a number of overdoses which may be attributed to one substance, but are really around mixing substances. And just want actually to any of you, if you have any thoughts on that.
Well, we know that about 15 to 20% of opioid overdoses also involve alcohol, and that's probably an underestimation. So the answer is absolutely yes. I mean, I think it's appropriate to mention that I saw Sanjay Gupta interview Bill Clinton, who was quite some time ago, about a loved one relative to the Clinton family somewhere along the way, or one of their associates who had participated in a party, young person, had been drinking and partook of opiates and overdosed and died. And I remember the interaction was a very poignant one, and it was on a major network. And I thought it was just an excellent description of this interaction and what the problem is. And I think the public needs to know about this in a major way. And I'm not sure how we go about doing that. Maybe the CDC or NIDA is already doing that. But I really think that, I mean, I speak to it every time I talk about alcohol and other comorbidities. I don't know, Wilson, what you think. But.
Well, I certainly think there's a gap in public awareness, and I'm not 100% sure all of our clinician colleagues are aware of the important interaction of sedatives like alcohol with the opioids. And part of the reason I'm not sure they're aware is when we look at prescribing data, not for alcohol, but for benzodiazepines, we still see that combination prescribed just all too often.
Okay. So let's talk about some of the health problems related to injection drug use. As we've seen increasing rates of injection drug use over time, I'm wondering, Dr. Dahl, if you have any concerns about the possibility of increasing rates of hepatitis C, HIV, other kinds of infectious disease, and if so, what CDC might be thinking about in terms of educating or working on prevention in this area.
Oh, absolutely. I mean, we've already seen dramatic increases in hepatitis C over the last few years, and the recent estimates are there are more than 20,000 new infections a year now, and we think largely due to the opioid epidemic and increased injection. HIV is also a concern. Fortunately, we don't see increases of the magnitude that we've seen with hepatitis C, but it's a possibility, as we all learned with the outbreak in Scott County, Indiana, where CDC went to assist on the ground with efforts there. And one of the interventions that was used there, I think, is something that we can use in other communities, which is kind of a one-stop shopping model for people to do, syringe exchange, medication-assisted treatment, all of the different, address all of the different issues that, in our silos we think of differently, but if you're a person with all these issues, you need integrated treatment. CDC did a study after the Scott County, Indiana outbreak to look at the potential for this and identified several hundred counties where we think this kind of outbreak could happen again. And so we are working with states to prepare and to look for early warning signs of this in their communities.
I highlighted for you the projects we're doing in rural areas, and that's being done in conjunction with our colleagues at CDC from your hepatitis division. And it's so important that these are public health concerns, and so it's a public health response in terms of how communities can organize themselves to implement effective treatment and effective prevention services to arrest the infectious diseases like HCV. I just want to put in a plug for the local area that I had dinner last night with a colleague who's in the public health department here, and Dr. McDonald was telling me about wound botulism seen in injection drug users who use Mexican tar heroin, an outbreak here in San Diego, that because they put a notice out into the community, there are actually a number of other hospitals who had odd cases that they couldn't figure out, and they realized that was a very, to me, I never heard of such a thing, but an unusual complication of injection drug use that unfortunately we're seeing in a few cases.
Well, I think you pointed out a couple of interesting notes, and one of them is around the use of harm reduction strategies, the use of needle exchanges, other harm reduction strategies that, while not treatment, certainly keep people alive, keep them as healthy as possible, and hopefully then help transition them into treatment. Could you each talk about what your agencies are doing to try to encourage collaboration with harm reduction organizations or to promote these strategies?
Well, I'd say our role is to study them. We're not in the business of either promoting or not promoting these until they're proven practices. So for instance, the oldest area had to do with syringe exchange and HIV prevention, and a lot of that work was supported by NIDA to demonstrate its effectiveness and to suggest that policies might be useful to promote syringe exchange as a way to reduce spread of infectious disease. We see similar data accumulating, but not quite as clear for hepatitis C because of the differences in the infectious nature of hepatitis C and how easily transmitted it is. So I think that's one of the questions, is when people have this reasonable idea that harm reduction strategies might be useful, well, we need to put those to the test. We're seeing people are proposing safe injection rooms in the US as a possibility. And I certainly hope that if those are mounted, that there will be researchers who can help us understand whether they're useful, whether they help move people along that trajectory into treatment and into recovery, or if they promote continued drug use, which of course would be the concern.
So I mentioned CDC's funding of 13 communities this year that's looking at linkage to treatment and including, that can include, talking to people at syringe exchanges, maybe even providing treatment at syringe exchanges. And we are, with the appropriation we just received from Congress, going to be putting out a notice of funding opportunity to states, and there we are looking at ways that we can encourage evidence-based linkages to treatment where we have them already. And as Wilson says, very importantly, evaluate what we're doing along the way. Also in the RFA I talked about, we're looking at interventions for primary and secondary treatment of opioid use disorder, so that if you read the language in the notice that's out now, that would include, harm reduction approaches and doing really rigorous evaluations, because as Wilson has said, we need interventions that work, and we need to build the evidence base on this.
Sure. Well, as he said, we have evidence based on needle exchange, for example. So that evidence base is out there. The next, I guess, question is, given our need to build an evidence-based addiction treatment infrastructure, you've mentioned some of the things that you're doing now in grants and et cetera, but how are the agencies really working together to ensure that this infrastructure as it's being built is being built consistent with evidence-based prevention and treatment, the knowledge that we have?
I think the evidence-based prevention that we've been working on, like screening and brief intervention, is something that we shared with NIDA, and we know it works for adults with alcohol. We have, I think, 6 grants out exploring whether screening and brief intervention works with adolescents and young people. I'm pretty sure NIDA has an equal number of grants on screening and brief intervention. So we talk to each other. Our prevention groups talk to each other. We write papers together. And Wilson, you may want to expand on that, but I think we integrate pretty well in those domains.
Well, certainly, I think from a research perspective, we have a really robust set of collaborations. But there's more to just the research to getting things implemented on a widespread basis. And it isn't just the federal government that it's a responsibility of. It's the responsibility of ASAM and other professional organizations to make sure that the evidence that we help generate reaches the patients who need to benefit from it. I was really excited by what George highlighted in terms of the patient navigator as a really novel way to guide the public, and hopefully now clinicians, to help their patients be linked to the level of care that they need. Because it's pretty daunting for people to figure out where they ought to be plugged in for alcohol treatment, and the same can be true of all the substances. So I'm really pleased with that advance and hope that we can build on that for other substances as well.
Okay. Well, I think, in terms of ASAM doing this, our work here really is around taking science and finding the science of medicine and the applied science, and coming up with what are these best practices, what are the guidelines. For our example of letting the public know, when we built those guidelines for the use of medications in the treatment of addiction involving opioids, we built companion products, including a pocket guide for clinicians, as well as a guide for patients and their families, to help disseminate those best practices right down to the level of people who really need to know what to look for when they're looking for treatment as well. So certainly.
I guess I would also remind us that healthcare is not regulated at a federal level for the most part. Almost all the regulation is at a state level. And so I turn to all of you all to think about your state organizations. I know my colleague from the Maryland, DC, Virginia area is right in front of me, and I look to her to guide us in terms of what we can do to influence state and local policies. What about the limits on buprenorphine treatment that exist in so many jurisdictions? Well, those are things that don't make any sense to most of us, but that's going to be up to you all to help advocate on behalf of your patients to change. We'll provide the data for you, and you all get to help make a change at the state government and policymaker level.
Oh, thank you for that plug. So ASAM is built of members who are part of not only ASAM, but their state chapters or their regional chapters. And because we are a chapter-based organization, we have the ability to support our chapters from ASAM with tools and information, and to help the chapters when there are regulations or bills or et cetera coming up that look like they're not evidence-based and et cetera. So that's one of the strengths of the organizations. For any of the members or new members to be in the audience, we encourage you to become active in your chapters. So thank you for that.
I'd just like to mention that we also have websites, and I'm not sure how they're utilized. We have an NIAAA website. There's a lot of great information on there. And if you can't find what you're looking for, then you should let us know. I was doing one of these gigs on training, and for, I think it was for APA or biological psychiatry, I can't remember. But anyway, I gave my talk about all the things we're doing in NIH on training. And then I said, you know, you can go to our website. So I went to our website, and I couldn't find training anywhere on our website. It was abysmal. And I was clicking away, and I hate websites anyway. Maybe you share that with me. But I made a change. I did a director's order, and we now have training on the little gray line, and you click once, and you go to training. So let us know if you can't find stuff.
More than 2 clicks and you're in trouble.
That's correct.
Oh, okay. Well, I have another slightly distressing question. It appears that long-standing divide between women who are using alcohol in a risky or dangerous manner and men has narrowed, unfortunately, because there's more drinking in women and not less drinking in men. Dr. Koob, can you maybe address that a little bit and let us know what NIDA is doing to try to communicate some of the dangers, maybe specific to women around drinking? And I'm thinking particularly the risk of what NIAAA is doing, the risk of breast cancer with drinking, which I think still too many women don't appreciate.
So this is a really erudite comment, but men and women are different. What we found epidemiologically is that women do what's called telescoping with the pathophysiology of alcohol. So they're more likely to have a rapid onset of liver disease, for example, or a rapid onset of negative emotional states associated with excessive alcohol use than men. And so Deidre Roach, who's here, Deidre, wave your hand, from NIAAA, Dr. Roach convened a meeting with NIDA exploring women's health and alcohol and drug use disorder, and a lot of really interesting questions came out of it, but one of them was on my slide, which is, of all the imaging studies that have been done at NIH, only about a quarter of them have actually separated out women in the studies. So we need to make more progress in that realm. Clinical studies have been powered with women for quite some time, but the analyses have not. And so that needs to be done. Second, NIH, when I joined the government 4 years ago, began to insist that all studies, all biological studies now involve both male and female subjects. So, and that includes even cultures of cells. So I think we're well on the way to start looking at some of these questions. But you know, who's the lady, Wilson, that runs the Office of Women's Health? Clayton.
Janine Clayton.
Janine Clayton has a slide where she shows about the differences pharmacologically between men and women. One of them is a drug that you're all very familiar with, Ambien, or Zolpidem, which is used as a short-acting aid for sleep, situational insomnia. But Ambien is actually metabolized twice as slowly in females. So if you actually, as a female, take 20 milligrams of Ambien, you probably shouldn't be driving an automobile the next morning because the drug hasn't fully metabolized. And I think what we're starting to learn is that this applies in many ways to alcohol, but probably many other drugs, and we need to study this. We need to know what are the differences, and we need it for both the deleterious effect, but we need it for the beneficial effect of any medications that we're employing.
I'll just put in a plug for looking at sex and gender differences in the opioid sphere as well. We know that women experience pain more commonly, and the prescription rates are equal or maybe even higher for women than men. There may be differences even in some of the receptor systems. So we're looking at the kappa receptor was just recently synthesized, and so we now know the structure, so we can begin to develop tools to use that structure to develop possible medications. And that receptor varies between men and women. So this may be a clue, and we may have some answers soon about why women experience pain differently and respond to treatments differently.
Well, speaking of this possible benefits of medication use as well, Dr. Koob, what's the latest research show on the impact of a moderate use of alcohol as well in terms of cardiovascular risk?
Actually, the latest paper came out yesterday in Lancet, and if I can summarize it adequately, maybe Wilson can help me, but my understanding is that they examined 600,000 subjects and concluded that there was a linear increase in the deleterious effects of alcohol in everything except myocardial infarction when you got above 100 grams per week, which is 7 drinks per week, because there are 14 grams in an American standard drink, and 7 times 14 is 98. So anything above that, there was a steady increase in harmful effects of alcohol. And so the conclusion from the Cambridge group that wrote this paper was that perhaps we should be modifying what we consider appropriate moderate drinking standards, which the FDA and we agree with. Right now, the FDA's guidelines are 7 drinks a week for females, or 14 drinks a week for males. And the argument would be based on this one study, which was quite extensive, and if supported by other studies, would suggest that maybe it should be 7 and 7 and not 14 and 7.
The other interesting thing in this study to me was that the risk rate was about the same for men and women. So unlike the difference that we thought was the case where women might benefit from a lower threshold, it looked like the threshold was about equal for men and women.
Right.
In this compilation of multiple studies, it wasn't a single study of 600,000. They took existing data
Right.
from many, many different data sets and put it together.
The data, as they become more and more clear, give us a real challenge. I was asked by a reporter yesterday, well, if ASAM knew that opioids were dangerous, how did this epidemic happen?
Well, it's all your fault.
It is our fault. We know that marijuana is dangerous, and yet, people don't really like to hear this message. And I think it seems like one of these issues continues to happen with alcohol as well, that as we see more and more data that shows, gosh, this really isn't good for you, it's difficult to get that sort of across to people, and people seem to be very surprised to hear that alcohol isn't really good for you. And I saw you talked about the data on liver disease. I wondered if you could speak maybe on cancer risk, for example, here, or other things that maybe we could tell, because sometimes we as specialists sort of know this, but we know it so well we don't say it sometimes. So is there anything you think might be particularly useful for us to kind of hang on to and get out there to our patients when we're working in prevention, or for people who aren't addiction specialists but are clinicians, to try to get some of those messages across?
We have a pretty large proportion of our portfolio dedicated to the division of metabolism and health effects of alcohol. And we have quite a portfolio on cancer, and we know that excessive drinking contributes to cancer. One of the more deleterious cancers, you're well aware, is pancreatic cancer, which is pretty much many times lethal, often lethal. We know from epidemiological studies, as far as I know, it's only epidemiological studies at this point, that there appears, and this has been published for a long time, there appears to be no safe amount of alcohol when it comes to breast cancer in women. So, I think physicians should be aware of that. If an individual has a history of breast cancer in their family, if there's a gene that will mark for breast cancer, I think those are decisions and information that should be put out there. We're very clear about the fact that excessive drinking and misuse of alcohol can facilitate the development of cancer. And, I personally have known individuals with severe alcohol use disorder who've died of pancreatic cancer. So, I mean, I've known that my whole life, basically.
Dr. Dow, there's been some confusion about the morphine equivalent dosage, and whether that, as states start to implement this or payers start to implement this, and et cetera, that those thresholds that are in the CDC guidelines for prescribing for opioids for pain, could you clarify how those thresholds are meant to apply to the use of opioids to treat opioid addiction, and how can we ensure that these guidelines aren't being misused and applied to addiction treatments?
Yeah, I'm so glad you brought that up, because we are always looking for opportunities to clarify this. I think there are a couple of misunderstandings about the morphine equivalent doses. They are intended as thresholds for caution when prescribing opioids for pain. For example, if you're going to go above 50, think about whether the benefits still outweigh the risk. Think about prescribing naloxone. Think about seeing your patient more closely. And these were based on studies of people taking opioids for pain and looking at overdose risk. We intentionally phrased the recommendations as when you're increasing the dosage, and we had different guidance about patients who are already on high dosages, and that the benefits and risks were different, and that it was very important to get patient buy-in and to go through the evidence on benefits and risks with your patient and make a decision together. That's a different situation. But we were very surprised and concerned after the guideline came out to hear that some anecdotal reports that payers were denying payment for opioids for opioid use disorder, or partial agonists for opioid use disorder. We had thought it was clear that the thresholds were never meant to apply to treatment of opioid use disorder. That's a whole different risk-benefit calculus, and I think that the studies would actually show in many cases you need higher doses to prevent overdose. We did have, we had a little footnote in the MME table in the guidelines saying, we're not providing a conversion factor for buprenorphine because we don't think it's associated with overdose risk in the same way that a full agonist would be. But once we started hearing these reports, we started looking for ways to make it more clear. So we have a fact sheet on our website about calculating morphine milligram equivalents, where we say clearly this is not intended to apply for opioid treatment of opioid use disorder. We were very glad to see ASAM's policy statement, which is on their website, which came out with the same messages that we're trying to get across, that these are not intended for methadone or buprenorphine for the use of opioid use disorder. We also sent a letter to ASAM in January of this year that you can find, I think if you Google CDC, ASAM, MME, that states very clearly in no uncertain terms that these thresholds were not meant to apply to the treatment of opioid use disorder. And I'd encourage, if you hear of clinicians, PDMP programmers, payers that are confused about this, show them these documents and let us know. We've had good success in our discussions with people so far about clarifying this, but we want to know if it's still happening.
Thank you. We appreciate the clarification and the assistance with this. We're almost at the end of our time, but we've had a very robust discussion, and as often happens, sometimes new thoughts come to mind during the course of a discussion. So I'd like to offer each of our panelists the opportunity to take an extra 30, 60 seconds. And if something has come up during this discussion that you would like to just comment on, or a last word from your standpoint, please let us know here.
I'd just like to say how much I appreciate ASAM, not just for inviting me to San Diego, but I really think that you guys and ladies are where it's at. And as Wilson pointed out, you can ultimately translate the evidence-based information that we generate to practice and to patients. And so bravo, and keep up the good work, and utilize us for that purpose.
I guess I'd just like to add that I'm impressed, even with our limited discussion in the last hour, about how many details there are to this specialty of medicine. And I'm so proud to see ASAM moving from a society of addiction-interested folks who had taken an exam for many years but didn't have the benefit of potentially being addiction medicine specialists. And there's what, over 1,000 of you that took the exam in the most recent example. I don't know the exact number. Over 1,200. And I'm impressed by how necessary that is, given the amount of misinformation that there is out there, and how much useful information there can be. That's why we need specialists to help guide the care of patients, and probably more important, work with the rest of the medical community to help improve the care that they provide, which is often where you see those errors taking place.
I just wanted to add that, we were talking earlier about the importance of getting the messages out about the effectiveness of medication, of MAT, medications for addiction treatment. And I showed in my first slide about the drop-off between even getting people into treatment and then if they're in treatment, are they in effective treatment? There's a number of people getting this message out, and organizations, SAMHSA says it, CDC says it, but I really appreciate ASAM. I feel like ASAM has been saying this most clearly and loudest, and I think that that's going to be a really critical message for addressing the opioid use disorder epidemic in this country, and I'm really glad ASAM is there to get that message out.
Well, thank you. Please join me in thanking our panelists. And thank all of you for attending. We are next up, I think, for our beach party. Okay. So I'll enjoy, and we'll see you at least first thing in the morning at the business meeting, at which there is breakfast.